Okay, so moving on, I'm going to do a bit of about the prescribing now. This is a pet topic of mine that I've been working at the CEG for the last year or so, and it's about reducing the use of inhaled steroids. So why are we looking at this? So in Tower Hamlets, it's mostly a good news story. We're really good at case finding and giving high quality annual reviews, but NHS Right Care, which compare us to our most similar CCG areas, find that we spend quite a lot of money on drugs, and despite this, we've still got quite high admission and mortality rates. The use of steroids in COPD has really been copy and pasted from asthma, and really the benefit is really concentrated at the more severe end of the spectrum, and that's primarily about reducing exacerbation rates. There are significant risks, and this is all from the Cochrane review a few years back, the most important one being pneumonia. The jury's out on the other ones on the right hand side. But for the mild to moderate group, the risks are likely to far outweigh the benefits of inhaled steroids. And needless to say, they're expensive. They're still inhaled steroids, and especially combination products, are still in the top 10 of what the NHS spends its money on medication-wise. I won't dwell on that, but I don't think you can see that enough today. For these mild to moderate patients, what we should be concentrating on is those few rungs at the bottom, so the flu jabs, the smoking cessations, and the pulmonary rehab. So how have we got to the situation that we're at where patients are on inhaled steroids regardless of their severity? Well, who could blame anyone for just following NICE guidelines? As you can see, all roads lead to inhaled steroids at the bottom of the chart, regardless of your exacerbation rate or your breathlessness. And this is a slide that you really can't see enough of today either. So this is the gold way of looking at the problem nuanced. When we're considering candidates for potential inhaled steroid withdrawal, we're really looking at two main things, and those are their spirometry and their exacerbation rate. And to fall in this high that really are likely to benefit from inhaled steroids, they either have to be severe or very severe with their predicted FEV1, so that's less than 50% predicted, or they're exacerbating, and the threshold that they use is greater than 2 exacerbations a year or any hospital admission. And you'll note that symptom severity doesn't really figure in that calculation. So over the last year, I'm sure a lot of you have been involved in this work. We've been trying to categorise our patients using the CEG guidance and the searches that you've had access to. But a big problem that we've come across is this bit here. So the exacerbation rate is coded very variably. So I'm going to, in this bit about identifying patients, I'm going to talk about how we've changed the things this year. So in terms of identifying patients who may still be eligible for ICS withdrawal, we're looking at those who have a confirmed diagnosis of COPD, importantly excluding people who have asthma. So again, the key point of today, inhaled steroids have a clear role in asthma, and patients with asthma or COPD asthma overlap shouldn't be withdrawn. Then we're looking at those with mild to moderate obstruction on their spirometry. The next bit won't be featured in the CEG searches or the metrics, really for accounting reasons, but it's important that you still consider it. So we should be looking at someone's exacerbation rate and their admission rate. It may not be very sort of obvious from the record, so that's going to be a sort of trawl back through EMIS and to see what's been going on over the last 12 months. We should mention the importance of eosinophils, and that's another thing to look out for, and that will be part of the search too. And then finally, we're looking at, it's all about who's been prescribed inhaled steroids in, it's actually the last 6 months. But the metric looks at anyone who's got a current prescription, so anyone who's had their their item, if you clicked end course, so it's off their current medication screen, it's counted as them having been withdrawn. So these are the resources where, in contrast to other areas of London, we're really focusing it on primary care. This is something that we found can be done close to home, doesn't need necessarily hospital consultants involved. And I'll show you some data on the success that we've had in the last 12 months. We've got some CEG resources, so we've got the guideline and the patient information leaflet, which are available for you on our website. And also there's, hopefully the respiratory MDTs are going to be ongoing over the next year, so if you've got any tricky patients that you're unstuck with, then you can always get support there. So this might potentially be the most useful bit of these 10 minutes. So this is really the nuts and bolts of how, if you've identified a patient, you're going to wean them off their inhaled steroids. So it's a gradual process, and really it should be done over a number of months. And there's not really an evidence base for this, but a kind of rough ballpark is about making changes every 8 weeks or so. The idea is that if you've got a patient on a combination product, say Serotype 500, you gradually go through the stages through the decreasing potency of inhaled steroids. And at each stage, keep maintaining their dose of bronchodilator. At each stage, they are likely to need some form of contact, whether that's a face-to-face review or a catch-up over the phone, and until you're finally at the end of the process, when ideally they should be just on their bronchodilator. It may be that they need to increase and potentially add in another bronchodilating agent. The other key things, inhaler technique, we'll probably hear a lot about today. It's an anxiety-provoking activity for clinicians and patients alike, I think, regardless of what the evidence base says. So ensuring that they have a management plan and a backup plan for exacerbations using our information leaflet is key. So this slide is really just to demonstrate the success that you've all been contributing to. So these are all your practices across the bottom, and orange is good, red is not so good. So this is all COPD. So got as far as 85%, which is amazing work in terms of reducing the number of people in that at risk in the mild to moderate cohort. So really, it's a kind of a good news story today. But keep up the good work. So in summary, we've got good evidence from randomised controlled trials that supervised stepwise reduction of ICS is safe in the low-risk groups. It's important to focus on these high-impact, low-cost interventions. And although the metrics and the accounting will be changing for this year, do still remember things like exacerbation. And I guess the final thing to say is that last year it was very much about reduction. This year the target will be very much about maintaining performance. There will be a threshold. So that's all I've got to say. Thank you very much for all of your efforts over the last 12 months, and thank you for listening today.